Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This podcast is about Right 7.8 of the Code of the Health and Disability Commissioner. We're going to talk about, can patients specify who looks after them? And this is actually part 2 of the podcast. So if you are interested, you can always go back and listen to our part 1. My name is Chow Yen Chen, and I am a medico-legal consultant at MPS and an anaesthetist for Te Whatu Ora. I'm very lucky today to be joined by Sarah Dalton, Director of the Association of Salaried Medical Specialists, ASMS, Dr. Sam King, Fellow MLC and GP, Dr. Tim Cookson, Retired Fellow MLC and GP, and also Mr. Adam Holloway, one of the partners at our panel law firm, Wotton, Kearney. Hello, everyone, and welcome.
Hi, Jan.
Hi, Jan.
So in our previous podcast, in part 1, we talked about Right 7.8 and some HDC decisions. Specifically, we were discussing patients making potentially racially discriminating requests, but there are other reasons why patients might want to specify who looks after them. And we're going to have a look at some HDC opinions for this. So there's a number of scenarios here where the HDC's made a ruling and given an opinion in relation to Right 7.8, but I think you would agree with me that a lot of these are about the patient's right to express a preference about who's providing them with care in very specific circumstances. And whenever this right is discussed by the HDC, they are very specific and they refer to the details of the clinical situation. So one example is about this 61-year-old patient who was referred to hospital with a history of changing bowel habit, mild hemorrhoids and bleeding. So the first surgeon provided care, but there were poor outcomes. There was wound dehiscence, and the patient requested to have another surgeon perform her follow-up surgery. This request was received, and she had a response from the booking clerk. She was told that this could not be accommodated in the public system. In the following year, in spite of the patient's wishes to be placed under another surgeon's care, that same surgeon who operated the first time operated to reverse the Hartmann's procedure. Unfortunately, difficulties arose when the tissue being stapled was too thick for the stapler, and the surgeon ignored the advice of colleagues and used force to effect the stapling and created a colovaginal fistula. Tim, would you like to talk us through some of the commentary around this case?
And if I can come in over the top, just before Tim does, and it might be helpful if people have just joined us for this episode to remind ourselves of Right 7, paragraph 8. And that's the right that says every consumer has the right to express a preference as to who will provide services and have that preference met where practicable. So that this case and the other decisions that we'll of the HTC will be discussing address how far that runs and how heavy is the obligation to try and meet an express preference where practicable. Sorry, Tim, back to you.
That's all right, Adam. Thank you for that clarification. It's always useful to know what we're actually talking about.
Yes, that's right.
So, I mean, just thinking about the case itself and the request from the woman, I think that's the first thing to consider. Is it reasonable for someone who's had a really bad outcome from a particular individual to say, actually, in future, I don't want to have that individual look after me? And where there are options, where there are other people available, I personally think that's a very reasonable request. And in fact, I would have thought from the clinician's point of view too, if a patient has requested to see someone different, that actually I would prefer another doctor to be looking after them rather than looking after them myself. So I think from a just a sort of straight practical point of view, it was a reasonable request to make, and I was kind of surprised that the patient was told that it couldn't be accommodated in the public system. So, as Adam was saying, that the right to receive services from a provider of one's choice is not an absolute right under the code. It is this where practicable bit, and so. In some situations, it's not going to be possible. There's a single surgeon who does that kind of surgery in that region, and so therefore the only person that she could have would have been that surgeon. That didn't apply in this situation, so there are quite significant limitations on those rights that are in Right 7.8 of the code. However, the onus is on the provider to show that they took reasonable steps to accommodate a patient's preference and that it was reasonable in the circumstances to refuse the request. And that's a general theme within the HDC complaints. It's the onus is on the provider to prove that what they did was the right thing, as opposed to having an onus on the complainant to prove it. And as I said, it was pretty natural for this patient to feel uneasy about having the same surgeon, but also having to discuss her request with that surgeon and to say to that surgeon, face to face, I don't want you to look after me. That's a tough position for a patient to be in. And so if she didn't say anything to the surgeon, it's very understandable why she wouldn't. So it would have been helpful perhaps if other staff had known about her request, to maybe try and have a chat about it and see if, despite the supposed hospital policy, that this request could not be met, that there could easily have been a workaround of some sort to ensure that actually everyone didn't get placed at risk. The woman herself, because she was being looked after by a doctor she had no faith in, and the doctor himself because, well, as it turned out, another error occurred and led to a complaint.
You'd probably consider that to be a breakdown in the therapeutic relationship, wouldn't you? Because she doesn't trust him to operate.
Yep.
And I think, as you mentioned before, the surgeon's probably feeling a little nervous because he knows the patient doesn't want.
Should have been,
and we don't know in the story whether or not, in this case, whether or not the surgeon had a choice about that.
So let's say, I think in this case he did know about it, did know about this request, but felt that for some reason the scheduling happened in a way that meant that he ended up being her operating surgeon again. But along those lines, I think I agree that if you know a patient has expressed that particular view about your care, it's quite difficult to be objective and to not practice in a really defensive way. And I think if you know about it, it's definitely worthwhile discussing with your colleagues and seriously considering referring this patient on to another colleague who can do the procedure. And
certainly at MPs, that's a relatively frequent conversation that we have with doctors as to how to manage that particular situation.
Yeah, absolutely.
And avoid being in a potential firing line.
What about the other issue? Like, I do get calls from members who say, I've got this really difficult patient, things aren't going well, I feel that the relationship is quite tense, and they keep questioning my judgment. I feel like they don't trust me, but they don't want a different clinician. Do I have to proceed? Do I have to operate on them? What about in that situation?
I think it's always that very clear discussion, communication with the patient is really important, because if you say to them, I hear what you're saying, but at the same time, you're really concerned about how I've done X and Y and Z. So I find it difficult to look after you in a way that you want to be looked after. And I can suggest a colleague to give a second opinion and see where that goes.
Yeah, the second opinion idea is a very logical one and a good one, because it may turn out that the patient actually then decides they prefer the new clinician and can start afresh. Or it may well be that the second clinician confirms exactly what the first clinician was saying and therefore restores some kind of confidence in the patient that actually, that the advice was fine and they should be following it.
How difficult is it to access a second opinion, given how hard it can be to get an appointment or a referral, whether it's with a GP or a first specialist appointment, currently in many parts of New Zealand? Is that, it sounds like a practical thing to do, but how realistic is it in our public system currently?
Well, I think if you're working in a major centre, you have colleagues working in teams in the same specialty, so it's perhaps easier to do that. But I agree, if you're in more of a smaller centre and there's one or two people in the region that does it, who all have waiting lists, it might be several months before you get a second opinion in a public system.
I think if you think about the best interests of the patient, if a surgeon feels that they can't provide the best of care, because let's face it, when you're operating, you don't want to be nervous going in, because you're going to be distracted, etc., etc. So if you think it's actually not in the patient's best interest for you to continue in their care, I think it's important that they opt out. Because what you don't want is for further complications to happen.
Exactly.
Which is, I think, what happened in this case.
Yeah.
So how does that play out, assuming it's a relatively straightforward procedure or, well within the competence of, for example, a senior registrar? Is there an option to supervise a junior colleague to perform the procedure if a second opinion is difficult or if there are limited people available? Is that an option?
Well, I think if your proposed treatment management plan is accepted by the patient, but the difficulty is about who's actually doing the operation or who that patient is liaising with, and you're clear with the patient that this doctor is a registrar in training and you are available to supervise, you could put it to the patient as long as that's really clearly communicated and documented. Because the HDC does talk about registrars who do the operation, and the HDC acknowledges that it's important for surgeons to be able to train. The case that we'll talk about is sort of the other way around, where the registrar wasn't clear about the fact that they're going to be doing the operation and that they'll be supervised. So if we move sideways a little bit and talk about whether patients can express a preference for to have a registrar or to not have a registrar, then the HDC has given the opinion that you need to be very clear of your role when you are consenting the patient and giving them information, that you are, whether A, you're going to be doing any of the operation, or B, you're going to be supervised, or C, just supervised in a remote way so that the consultant is not present. And they've made rulings about that, breach findings that where there's been a complication and a complaint, and the registrar hasn't been absolutely clear with the patient that they're going to be doing all of the operating. They said, I will be supervised and I will be working with this consultant. But they did the entire operation and there was a complication. And there was a critical finding that the registrar wasn't absolutely clear with the patient that they're going to be operating, they are supervised, but they are doing the procedure.
I think most members of the public really struggle to understand what different types of doctor there are, and what different types of clinician there are, and because it's hard to get your head around, and I think if you are trying to explain that to people, that is quite challenging. I just can't overemphasize how hard it is for members of the public to understand. They don't understand typically different scopes of practice, let alone the difference between a consultant and a registrar or a house officer, or it's so I think there is an important series of conversations around consenting, right?
So if you think about the consenting, do you think that it's necessary for the registrar to explain what level they're working at, whether they're a senior registrar or this is my first registrar job?
Well, I think, again, that would mean nothing to most people, so it has to be in context. But I was just interested that in the HDC case, it was really a dissatisfaction of the patient with the outcome of the initial surgery, right, that caused them unhappiness about that particular surgeon and expressing a preference for a different surgeon. It seemed to me that, as you said, if they understand the treatment plan and the treatment plan isn't causing them concern, it's the actual specifics of the perceived competence of the person doing the operation. And in that particular case, it seemed to have been borne out. There was a further complication that a senior registrar being supervised might be the more appropriate person if it was seen to be an appropriate thing for them to be doing, given that the initial surgeon hadn't had a good outcome in the last surgery and perhaps might be feeling anxious or uncomfortable about what was going to go on in the next surgery.
Sorry, Sam. I was just going to say I think a risk with this developing line of cases, and that doesn't mean necessarily that I think they're wrong, but as we see these HDC opinions about needing very explicit conversations around who's going to do what and who's still quote unquote in training and whatever that means to a member of the public, you might drive to a position where you're asking clinicians to have the sorts of conversations that will inevitably lead to the patient saying, oh, well, I want the boss to do it. and that's not realistic from a resourcing perspective, and it's not realistic from the perspective of having a health system that is able to train new doctors. So wherever we come to in a landing on these things, it would be a shame if the position we reached is the sort of conversation you need to have inevitably leads to, would you like me to do it, or would you like this other person to be holding the tools and they've been doing this procedure for 15 years longer than me? Because most patients would say, well, I'll have the older one, thanks.
Yeah, I completely agree.
And that isn't necessarily borne out in terms of outcomes. If you have an advanced trainee registrar who might have done lots of a procedure without a supervisor in the room, and the teaching element is being able to go and discuss those cases later, or to have someone on shift who you can call in if you encounter a problem. I think ideally we need to become mindful or more sophisticated about how we expect doctors to have those conversations so that you don't get to a inconvenient place in terms of being able to just provide care in a country like ours where you have one public health system and we need to train doctors.
I think too, though, that registrars invariably are not permitted to operate on their own until they've been supervised presumably the SMO has signed them off and say, yes, you're really good at this now, you can go and do this and I'll be hovering, So it'll be a gradual hands-off process. So I can't imagine that any registrar would want to dive in and do an operation that they're not competent to do.
So that's a really interesting point, isn't it? That while there are things to learn from HDC findings, they often are dealing with exceptions rather than the rule. They're dealing with poor outcomes or complaints. They're not necessarily dealing with the majority of cases where everything was fine. So while we need to learn from them and we need to observe what they're saying, they might not be the best driver of practice overall in terms of consenting or...
Yeah, so imagine a scenario like Sam just said. If you're going to be doing the procedure on your own, you would have been signed off for it. So, is it okay to say to a patient, I'm Dr. So-and-so, I'll be doing your procedure, I'm approved to do these procedures, and I've done, lots of them before. Do you need to go on and say, but just so you know, technically speaking, I'm still a registrar, which means that I haven't become a fellow and I'm not what the system regards as a specialist. And there are people in the department who are specialists, but that's not who we're proposing do your procedure. Like, what does that conversation need to look and feel like to meet the requirements for the HDC? Perhaps we should look to some of these other cases and see if they help answer that question.
Just with this particular case, it's not uncommon for a patient, for example, to see a surgeon in private, then they get pushed into the public system, and so that increases the expectation of who it is that's going to be doing my operation. And I wonder where that's where some of these complaints come from.
Presumably, too, you would be, I don't know, you would say, I'm Dr. X and I work in Dr. A's team and I will be doing your operation as initially discussed with, did I say Dr. A?
Yes.
Yeah, I think it's pretty hard of the HDC to be critical of this because if I remember correctly, all patients, when they're signing in, sign a form that says, I understand that my procedure will not be done by, not done by any particular doctor. So it's quite clear in that initial document that you sign an expectation that you won't have a named doctor doing it. It'll be the team or whatever. So there's always the consent thing, was that properly explained to the person at the time that they signed the form? And usually that doesn't happen, so it leaves a gap. But at least patients are forewarned that this is the way the public hospital system works. There is no guarantee that you'll have the consultant doing your surgery. Yeah,
and just a caveat about this particular case, the HDC, this article was written in 2017. So he makes and this was Anthony Hill at the time, my findings in this case were specific to the particular circumstances. And it was a particularly delicate procedure, an epiretinal peel that as the expert opinion had stated, is at the extremes of fine manual dexterity. So I think it's very specific to this case. In his defence.
Yeah, but I would hate for Adam's scenario to come about that, doctors have to explain themselves so much and then offer other options, which actually the hospital really can't accommodate.
Can't accommodate. And he does say at the start that they've got to have the right to information that a reasonable consumer in that consumer circumstances would expect to receive. So I think, to your point, Sarah, that you're a reasonable person who's receiving healthcare service from a surgeon before them has been informed that they're receiving care by a surgeon suitably trained who's going to do the operation, and they give them an appropriate discussion of the risks and benefits and what they propose to do. So it's that reasonableness test.
So I think to reduce risk while being realistic about what the public service is able to offer, the conversations earlier on in the process can be improved, or more thought can go into those to say, to actually manage expectations. I'm going to be putting you forward for this operation. Normally, Mr. So-and-so surgeon would do these in this region, but it will depend a bit on, which list you get on and when this is going to happen. So you can, earlier on at a clinic phase, actually give information about that contingency around what is going to happen. And I think the bottom line, and that this comes out of some of the HTC cases, is you do actually need to know who's doing the procedure. And I think the HTC will hold firm on that. So it needs to be communicated before pre-anesthesia medications.
Yes.
That the people doing the procedure will be this person and this person, or one if it's only one, and that the patient's actually met them.
Yes.
And a specific request if it has been made for a particular person or a particular circumstance. If that's not being met, the people explaining that to them need to be aware that that has been made, right? Saying, we know you requested X, but you're going to get Y, and these are the reasons for that.
That's right. And if there is a change in what is anticipated, then the earlier that's communicated, the better. And one of the these HTC cases that we've been talking about comments on the fact that the patient was going forward for a procedure on their foreskin. They were expecting a particular surgeon and then confronted at the last minute with an alternative. And in a number of cases around consenting, the HTC is willing to be critical about forcing patients to make decisions that are meaningful for them immediately before going ahead to a procedure. They don't see that, understandably, I think, as a great environment for getting informed consent. People are already at hospital, everyone's there waiting expectantly. It's a lot to ask of a patient to say, oh, actually, hold on, I've only just met this new surgeon, I need to stop and have a think about that. I think a lot of people's natural reaction would be, being Kiwis, they'd be like, I don't want to make a fuss, fine. And afterwards be regretful, particularly if something goes wrong, that they were put under pressure to make that decision, even sort of not necessarily explicit pressure, but felt pressure to go along with what the plan was. So if you're going to be making a change, try and do that earlier on in the clinical journey if you can. And if you have to do it at the last minute, you also have to be prepared to say, if you're not comfortable dealing with this right now, we can delay.
It's a really interesting point, because I know clinicians are really thoughtful about these things, but it's your day job and you do it every single day. Patients going in, particularly to an operation, it's a huge deal. It might be the only time, if they're lucky, it might just be once in their life that something like that happens. And it's a very challenging situation for a person to be in. Whereas for the clinical team, it's what you do most working days. And it's a massive imbalance of impact, that kind of conversation about a change or something that patient wasn't expecting.
The other problem that occurs with those changes is that often, well, judging by the cases we've had at MPS, the second surgeon, for example, may not have a clear understanding of what the patient thinks is going to happen, and so things end up being different from what they expected, or there wasn't proper documentation, or the documentation wasn't read because the surgeon had been called in at the last minute, and so big potential for patients' expectations to be dashed, and therefore increase the likelihood of a complaint.
I think it's very normal for patients to be put on a list where the surgeon has never met them. 100%. and because we hear about this a lot from our members, and the operating surgeon then consents the patient while they're there waiting to be put to sleep, which is obviously not ideal. And in this particular case, it is unlikely that a complaint would have arisen had everything gone according to plan, had the patient got the operation that they were expecting. It was the fact that something went wrong. Then the patient's been primed to complain because they know, oh, that's not the person I was expecting. And because it wasn't that person, look what's happened to me now. Yeah, so if you're going to go in there and operate on a patient you've never met before, I think it's really important you do look at the notes. And, if you are the operating surgeon, the responsibility falls on you to ensure consent is appropriately done. And, I mean, I can understand it. It's a rush. You've got a big list and it's a routine operation as far as you're concerned. But that's when often things go wrong and complaints arise.
Yeah, that's the frequent comment from the HDC, is that they expect you to see them beforehand. If you didn't see them in clinic, see them beforehand, talk to them about the procedure, what you're going to do, get their consent. So essentially they've been consented twice.
Mm.
Consent is a journey, not an event.
100%.
It's not a signature on the bottom of a form either.
That's right.
We've actually got some good podcasts in previous episodes on the whole issue of consent if our listeners are interested. We talk a lot about surgeons. I'm not sure why. There's a whole lot of gynae cases that we discussed. We weren't picking on gynecologists, and I don't think they're a greater risk than any other clinicians. It was just so happened they're the cases we used.
So let's talk about, what if a patient says, I'd really like a female provider.
I can totally understand why they'd want a female.
Well, me too. But what would you say? Is that being discriminatory? Is that, they've expressed a preference? What do you think? Looking through the HDC cases, there haven't been obviously a complaint about this issue, and they haven't commented on Right 7-8 where it hasn't been accommodated. But I can understand some people have said that there's often a clinical reason for their request, that it might be an intimate examination and they would feel more comfortable having a female provider. But is that reasonable? Is it a reasonable clinical request?
I think it is a reasonable clinical request, and there probably aren't cases because that's how people view it. And also, which is a great thing, generally speaking, it's probably a request that we are able to accommodate in the health system, and increasingly so over time. There will still be, I'm sure, situations where it is not possible to meet that request. The particular specialty that the patient requires care from in that area just happens to not have a woman available to do the job, and then it's a conversation that you need to have. But if in general terms, a request like that doesn't concern me from a legal perspective, and I think it's quite a fair thing to accommodate if the service can. What do others think?
Well, I have my own bias because I always seek out female doctors and dentists actually where I can. So I kind of understand it as a preference. But I also understand that in the public system it's not always possible, and I've experienced that as well. So I think people just need to understand the limits of that. For example, my GP's female, but if I need an appointment and she's not available, there's a lot of practices that have online booking systems now that list who's available to see. And again, I would still probably just look through and choose a woman where I could. And if I couldn't find one, kind of have that internal conversation. How sick am I? How urgently do I need this appointment? But I think when it comes to a referral to the hospital, understanding that, you know, if someone's able to see you, you're quite fortunate, irrespective of their gender or any other characteristic that they have. If you're able to get an FSA, a first specialist appointment in a timely fashion, you grab it.
Yes, I think a lot will be sort of anticipating patient expectations and early on and addressing those early on. So, you know, it might even fall to the GP to say, look, I know you always come to see me because I'm a woman, but look, when I refer you to the hospital for your gynecological problem, actually, I can't guarantee that you'll be seen by a woman because it really will depend on who's available at the time. So setting up the expectation early on can be really helpful.
To be honest, I've never had a patient who said to me, I only want to see a female at the hospital, a female doctor in the hospital. And I mean, when people go private, they might have a preference, but in the hospital, I've not actually had that where people have asked. So I'm not sure how big of an issue it really is.
It is an interesting point, though, that we often talk almost in abstract terms of trying to develop a medical profession that better reflects the diversity of New Zealand specifically. And I guess when you start having these conversations about preferences, that while there are limits of reasonableness around where people's preferences sit, around who treats them or how their treatment program runs, the greater the degree to which we're able to train and keep our own doctors working here in New Zealand, the more that they will start to reflect the breadth of New Zealand communities, and we will be in a better position not only to meet preferences but actually also to have those vibrant and dynamic conversations about what that means and about best meeting care and making sure that the statistics that we do know about access to care or missed opportunities to give best care might be better met.
Absolutely. So thank you so much all for coming today. Anyone got any last points that they'd like to make?
I think in the conversation that we've had in the previous podcast and this one, it's really about thinking carefully about the policies you have where you are working to ensure that where you can accommodate reasonable requests, you do so, and but that you also consider staff safety and risk to staff as part of that equation.
Yes. Yeah. So if you've got any specific questions or queries, you can always contact us on our 0800 number to discuss further. But I'd like to thank everyone for coming today, and thank you all for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.com.